Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we wrap up our vascular neurology umbrella by spotlighting a fascinating posterior circulation stroke, lateral medullary syndrome, also known as Wallenberg syndrome. This one is high yield, memorable, and honestly kind of weird in a board relevant way. Let's dive in. Did you know the syndrome is named after Adolf Wallenberg, the German neurologist who first described it in 1895? It's a rare but classic brainstem stroke that's frequently tested because of its distinct constellation of symptoms. Let's dive a little deeper into the Kinder Patho. What is a lateral medullary syndrome? Well, lateral medullary syndrome is a posterior circulation stroke due to occlusion of the posterior inferior cerebellar artery, or PICA, or the vertebral artery. This leads to an infarction in the lateral part of the medulla oblongata. This region of the brainstem houses several key structures, including the vestibular nuclei, which can cause vertigo and nystagmus, the spinothalamic tract, which causes pain and temperature issues on the contralateral part of the body. It houses the spinal trigeminal nucleus, which causes loss of pain and temperature on the ipsilateral face, and nucleus ambiguus, which causes dysphagia and hoarseness. It can also cause sympathetic fibers issues, including ipsilateral Horner syndrome and inferior cerebellar peduncle, which can cause ataxia. So, how do these patients typically present? Well, they can have dysphagia, hoarseness, or hiccups. They can have vertigo, nystagmus, nausea, and vomiting. They can have ataxia on the ipsilateral limb, loss of pain and temperature on the ipsilateral face and contralateral body, and ipsilateral Horner syndrome, like ptosis, meiosis, and anhidrosis. Think crossed findings. This is a buzzword for a brainstem lesion. Well, how do we make the diagnosis? An MRI with diffusion-weighted imaging is the most sensitive for posterior fossa infarcts. An MR angiography or CT angio is used to evaluate vertebral and PICA occlusion. How do we manage these patients? Well, supportive care and stroke protocol are going to be our mainstays. We want to initiate antiplatelet therapy like aspirin or clopidogrel. We want to initiate BP management per stroke guidelines and a swallow evaluation to avoid aspiration. We also need to consider rehabilitation, especially for dysphagia and ataxia. Thrombolytics? Only if within the time window and no contraindications. Most of these strokes go unrecognized acutely due to the unusual presentation. All right, now let's look at the book med versus the street med. So book med, you're memorizing those cross neuro findings: ipsilateral face, contralateral body, Horner syndrome, and hoarseness. Street med, you walk into the room and the patient says their voice sounds weird. They're dizzy, they keep falling to one side, they feel numb on opposite parts of their body. That's your red flag. So some quick clinical pearls. Think don't cross me. Crossed findings equal cranial nerve plus contralateral body equal brainstem stroke. We want to look for Horner's and hoarseness, which is a huge clue for the lateral medulla. An MRI is better than CT for the posterior fossa. And remember, PICA equals poor circulation and ipsilateral cerebellar ataxia. All right, now some practice questions. A 65-year-old male presents with vertigo, hoarseness, left-sided ataxia, and decreased pain and temperature sensation on the right side of the body. What's the most likely diagnosis? Is it A, medial medullary syndrome, B, lateral medullary syndrome, C, pontine infarct, or D, cerebellar hemorrhage? I'll give you a few seconds. If you said B, lateral medullary syndrome, you are correct. Remember, cross symptoms and cranial nerve involvement with ataxia point to Wallenberg syndrome. Which of the following findings is the most characteristic of lateral medullary syndrome? Is it A, ipsilateral motor weakness, B, bilateral sensory loss, C, dysphagia and ipsilateral Horner syndrome, or D, expressive aphasia? If you said C, dysphagia and ipsilateral Horner syndrome, you are correct. Remember, damage to the nucleus ambiguus and the sympathetic fibers explain the hoarseness, dysphagia, and Horner syndrome. Okay, so some final thoughts. Lateral medullary syndrome is a can't miss stroke, and a strong reminder that not all strokes present with slurred speech and a facial droop. If you catch the crossed findings early, you'll look like a neuro rock star. Next up, we shift from vascular neurology to neuromuscular and peripheral nerve disorders, starting with central motor disorders and cerebral palsy. Know someone on clinical rotations who might miss this? Share this episode and help them nail neuro on the go. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.